Welcome to Clinical Medicine 2. In this presentation, we'll discuss the role of screening for red flags, non-organic signs, depression, and fear avoidance beliefs in patients with low back pain. The objectives for this presentation include describing the clinical presentation of individuals with non-organic signs, depression, and fear avoidance, and to formulate and implement an evidence-based physical therapy treatment plan for a patient with fear avoidance beliefs. It is important to do a review of systems on all of our patients, and patients with low back pain will be no different. We're going to ask those questions about general health of all of our patients, including patients with low back pain. We're going to pay particular attention to the question of paresthesia or weakness. We want to know about that because the lumbar spine is definitely an area that we could potentially get neurologic signs and symptoms. So we want to ask about that. And again, any of those questions, if there's a positive response, we're going to follow up with trying to have an understanding of how long they've had the symptom. Is there an appropriate explanation for it? And how's it interfering with function? Is the MD aware of it? And if the physician is not aware of it, we're going to get these patients back, especially if there's duration and lack of an explanation for why they have these particular symptoms. And once again, it could be completely unrelated to the patient's low back pain, but you may have a patient who tells you that they have fatigue, right? And it could be completely unrelated, a completely unrelated complaint to their low back pain, but they still need to be followed up for that. When we start thinking about sinister pathology, we'll talk about a few conditions in a second that are concerning, but we also have to think about visceral structures potentially referring to the lumbar spine. And we would certainly see potentially gastrointestinal and urogenital structures referring into the lumbar spine. So the questions for number 4 of the checklist, number 5, and number 6 of the checklist could certainly be fair. We may ask questions about gastrointestinal function. We may also ask questions about the urogenital system as well, because if those organs, once again, are pathologic or dysfunctional, we could potentially get symptoms referring into the lumbar spine that could potentially mimic a musculoskeletal problem. We've talked about the importance of the review of systems, and we've also covered a couple of concerns as you work through your history that may lead you to be suspicious over a red flag finding. And so it's important to note that red flag findings and sinister conditions can mimic low back pain. Just like we talked about in the last slide, you could potentially have dysfunction of a gastrointestinal urogenital organ that could refer to the lumbar spine, and it could be perceived as a potential musculoskeletal disorder by the patient and by a provider. And so it's important to note that when we begin to look at red flag findings for the low back, we're talking about those visceral organs, but we're also talking about conditions like cancer, cauda equina, infection, fractures, abdominal aortic aneurysms, and inflammatory disorders like rheumatoid arthritis and ankylosing spondylitis. And I think as you go through your history, you're going to start to ask questions, and you're going to want to know, especially in patients who don't get better, is this a red flag finding, and am I concerned about a sinister condition? And so first and foremost, when we talked about the history of a current condition with respect to low back pain, we want to know, is the patient getting better, worse, or staying the same? And in patients who have acute low back pain, if they're not any better in 30 days, that should raise suspicion. Now, if you're dealing with folks with chronic low back pain, they may not have an appreciable change over the course of a month, but eventually they will get better. The key here is that we're talking about these are acute presentations most commonly, and we're looking for at least some improvement over the course of 30 days, because these conditions here that we're describing will not get better over the course of 30 days, and only get worse. And so when we start talking about the prevalence of some of these, the one that you'll see likely the most in your practice are going to be spinal fractures. We've talked about those already with respect to the hip, but the risk factors are older individuals, especially women who are postmenopausal, folks who have taken corticosteroids in the past, and then folks who've had trauma. And so you're going to see fractures of the spine in individuals, and you'll be treating them for that likely, but they also may come in with a complaint of back pain, and it could be related to a fracture. Those need to be picked up sooner rather than later. Get those folks imaged and treated appropriately. These other conditions on here, though, they are a concern, and we want to get them to the appropriate provider as quickly as possible. The one condition on here that really has a time element to it is cauda equina syndrome. These are folks who are going to have progressive neurologic signs and symptoms. They're going to have numbness and tingling down their legs. They could have saddle, paresthesia, or anesthesia. That's changes in the groin and rectal region, and they could have global weakness of their lower extremities. They'll also have difficulty initiating a urine stream, and so all of that combined together, we should really be concerned about cauda equina syndrome. Those individuals have to be seen within 48 hours and decompressed with respect to surgical intervention, or they're at permanent risk. They're at risk for permanent neurologic and urologic dysfunction. And so that's the one on here that's probably most time sensitive. Of course, fractures and infections are as well, but cauda equina syndrome is one that if you don't catch this early on, they can really be in a jam long term. Infections for sure as well. That's another one we want to catch early. But again, we're going to be screening for red flags, and if these conditions come up, let's get them to the appropriate provider so they can be potentially imaged and worked up for these conditions. This is a figure that we routinely give the physical therapist to help them understand some of the questions that they can ask to either begin to rule in or rule out concerns over these different sinister conditions. And so in this particular table or figure here, we see the conditions on the right-hand side and then the questions on the left-hand side, and they've darkened out the boxes that correspond to the questions that would be concerning. So for example, we've talked about cauda equina syndrome already. We talk about difficulty with bowel and bladder function. We talk about saddle anesthesia and widespread or progressive motor weakness or potentially sensory disturbance as well. So all that would lead you to have some concern over cauda equina. With respect to spinal fractures, you can look at that. Again, age over 70, trauma, could be a minor trauma in someone who's older, and then potentially the use of corticosteroids as well would lead you toward concerns over fracture. And so I'm not going to ask you to memorize all these different questions. That's not the point of this. Just to know that if you are concerned over a sinister condition, you can look back through your history, begin to look at the questions that you're asking, and begin to change your index of suspicion, whether or not something is present that's sinister or not. We've presented this slide to you previously, and I think it's worth mentioning again as we begin to describe this content in this particular lecture. This particular information is very helpful when we try to establish prognosis. Now, the positive side to prognosis is, when do we think the patient is going to improve? When do we think the patient is going to return to work, sport, etc.? However, there's also a negative side to prognosis as well, in terms of what are the chances that this individual will develop chronic, persistent, disabling low back pain. What are the chances for that? And so in this particular study, they looked at what factors have the highest likelihood in predicting which individuals are going to develop persistent, chronic, disabling low back pain. And they found out that 3 of the 4 top predictors are nonorganic signs, maladaptive pain coping behaviors, and psychiatric comorbidities. And so we're going to spend time in this particular talk describing these 3 factors, because if individuals come in and have these 3 factors, we want to identify them early on and get them to the appropriate professional to help manage their pain. And we'll also talk about strategies that we can do as physical therapists to help with the recovery of these individuals as well. The number 1 predictor of individuals developing persistent chronic low back pain was the presence of Waddell's nonorganic signs. And in a moment, we'll show you a video that takes you through these in a bit more detail. But it's important to note that these particular signs and symptoms are typically related to individuals who we've thought been malingering in the past, right? That means individuals who are potentially embellishing or potentially over-exaggerating their symptom profile. Now, this can be due to a variety of reasons. I mean, it could be due to the fact that they've been to multiple providers and they don't feel like they've received the care that they need, and so there's a tendency in those cases for some folks to potentially exaggerate their symptoms. It has been reported in individuals who potentially also are potentially having behavior that could potentially be drug seeking, where they exaggerate their symptoms. Part of this presentation as well is also consistent with consistent emergency admissions to the hospital and an individual who says that they have not had any pain-free episodes with respect to their back over the course of the past year. And so, again, there's some exaggeration in that part. There could be potential litigation in someone's recent history, and that could be a factor related to this. And sometimes we've seen it even where there's a monetary concern with something like a workers' compensation case. And so bottom line is that it could truly be multifactorial. It could also be related to psychosocial conditions, psychological conditions like depression and anxiety. And so there's many factors that can be related to why these non-organic signs are present. And all that means is that there just is not an anatomical, biologic reason for why these symptoms are present. Right? There really is no true explanation for it based upon the person's scans, etc. And so when we evaluate patients and we see these non-organic signs being present, I think that these are patients that need to have further evaluation in terms of psychosocial overlay. Are we dealing with depression? Are we dealing with fear avoidant behavior? Are there other factors in this patient's history that are really beyond our control? And so it's very important in these cases to keep the physician involved. It's very important to potentially get these individuals with a pain counselor, somebody who can evaluate their current social situation and evaluate their psychological well-being as well. And so let's go over them just quickly. And if you look at the list here, the first one there is overreaction. So these are individuals that when you meet them for the first time in the waiting room and bring them back to the treatment area, you're going to notice grimacing, sighing, limping, just a general overreaction to their condition. They're going to have tenderness, meaning that there's widespread sensitivity to very light touch of superficial tissue. Axial loading, what that means is the patient's in standing and we provide a very, very gentle axial load on the skull. Nothing really that would load the spine in a significant manner, but the individual is going to have an increase in symptoms with that. Rotation, we are going to rotate the shoulders and pelvis passively in the same plane, so the low back is not really moving at all, and that's going to increase their low back pain. And then finally, straight leg raising. We're going to have the patient sit and extend we can extend their knee, and normally there's no pain with that. But then when we lie the patient down and we do a passive straight leg raise, usually it's very minimal, where the patient we can elevate the leg to a very minimal degree, maybe only 20 or 30 degrees before the patient says it starts to irritate their back. And that's not consistent with somebody who can do a full knee extension in a sitting position. And then finally, motor and sensory, we'll have an inconsistent exam with respect to our strength testing as well as our sensory examination as well. We'll typically see multiple muscle groups being weak, and we'll also see multiple dermatomes being affected. Again, these are individuals who are likely going to have a scan, and all the pathology there is not necessarily suggestive of something sinister. But these are folks who come in with very, very high levels of pain. They really haven't had any pain-free episodes over the course of the last several months up to a year. And these are folks who have multiple medical visits over the course of a year as well. So how many do you need to have positive before you start to get concerned? Well, you could potentially have one or two. right? We could potentially have one or two, and those may not necessarily always be consistent with non-organic signs. If you have 3 or more, that's the point where you really have to get concerned. You really have to get concerned if you see 3 or more of these signs. Those are individuals we want to get back to the physician with an appropriate referral for a pain counselor. Again, before you do that, I would go ahead and screen for depression. I would screen for fear avoidant behavior. I would also get some understanding from the individual about their current social situation as well, and determine if there are any factors there, just so you can help the physician with some decision making here. Again, we're not judging individuals with respect to how they're acting or the rationale for it. All we're doing is gathering data, right? And we're going to make some decisions based upon that to ensure the appropriate professionals are involved in the care of this patient. And so the link on this page provides a brief video that will help you understand a little more about these Waddell's non-organic signs. Unfortunately, the video is copyrighted, so I can't post it right into the PowerPoint presentation. So I would ask that you cut and paste the link and just drop it into your web browser, and you'll come up with the video, and take a moment and review that. I think it'll be very helpful for you. Depression is another condition that can potentially lead to persistent chronic disabling low back pain. And so this is a condition we want to screen for. We'll use the 2 questions at the top of the graphic here as our screening methods. First, we're going to look for the symptoms of depression. Second, we're going to want to determine if those symptoms have been interfering with the individual's ability to function. And if we see yes to one or both of those, and there's not a clear explanation for it, those are individuals we're likely going to want to look at further. And the reason I ask that is because we want to know if the symptoms are related to their current medical condition, meaning their back pain. If the symptoms are related to the back pain and we ask the person, if we got your back 100% better, would you still feel depressed? They're likely going to, they may say that they'll no longer be depressed. If you get my back pain better, I'll be fine. I won't have these symptoms. The depression's related to the back pain. In that particular case, it's on us. We can manage that person. But if they say that the depression's related to other factors in their life, and even if their back was 100%, they're still going to have symptoms of depression, those are individuals that we want to refer out to back to the physician. And the physician's going to do a clinical interview, and they're going to assess for those symptoms at the bottom of the graphic. And we're looking for 5 or more of those symptoms over the course of a 2-week period to make a diagnosis of clinical depression. So again, if a person tells us they're depressed, they're having little interest in doing things, it could be related to the clinical condition that we're seeing them for. We want to make sure that we always get the explanation for why these particular symptoms are present. We've talked about that a lot. And if those depressive symptoms are related to their current clinical condition, let's get them better. That way they're not going to have that anymore and they'll be fine. But there are individuals that even if we get them better, they're still going to have these concerns of depression. And those are individuals we want to make sure are managed appropriately. And so here's the first page of our patient intake questionnaire that we've presented to you several times over the course of the year. And if you look 2/3 of the way down, you'll see those 2 depression screening questions as being right here, and we can use that to screen our patients for depression. There's also that 3rd question on there. Is this something you'd like help with? And in part, that really relates to if the individual feels that care for their potential depression is indicated. And again, this relates back to what's causing their depression. If it's related to something outside of what we're doing in physical therapy, they'll likely say, that they would want care. If it's not, they'll say that, if it's a physical therapy related issue, and that's why they're depressed, their knee pain, their back pain, they're likely going to say no, they don't want care for that. The other part of this is that many times depression, there's a stigma associated with it, and many times even though patients have these symptoms, they could potentially say they don't want care for it. We may find that out. We may find out that depression is also related to other factors that are beyond our control in physical therapy. Those are patients that we don't want to push too hard, But at the same time, we want to make sure that we evaluate them down the road. How are they feeling? Right? Not something we're going to continue to push, but how are they feeling? Because at some point, once again, they're going to develop a trusting relationship with you. They may take your advice and get them back to the physician for a further workup on that. So again, the depression screening questions are there. I would go ahead and screen them, understand the importance of positive responses, how to follow up on them, because again, the last thing we want is to miss this and have the patient develop chronic low back pain because of depression that they haven't received care for. We presented the American College of Physicians clinical practice guidelines to you previously, and we'll take some time here and review those findings with you. And so when we begin to look at how does psychosocial overlay begin to influence the care of individuals with low back pain, we look at the recommendations here and we see that it really begins to challenge individuals who have chronic low back pain. And we see the treatments that are consistent with that. When we begin to look at the treatments that could potentially help someone who's potentially depressed, we begin to think about multidisciplinary rehabilitation. We begin to think about mindfulness-based stress reduction. Things like Tai Chi and yoga, where we see a mind-body connection, are very, very powerful with respect to treating individuals who may potentially have psychosocial overlay. Progressive relaxation, again dealing with stress and anxiety. Operant therapy, things like positive and negative reinforcement strategies, and then cognitive behavioral therapy, where we really address, the thinking that has become maladaptive, and now that's influencing their behavior. So those are factors, or those are treatments that will definitely be indicated for individuals with psychosocial overlay, and we see them for individuals with chronic low back pain. And that's really the population we're most concerned about. For these individuals with acute and subacute low back pain, we can use our treatment-based classification scheme. We'll likely screen them for fear avoidant behavior as well as depression, and we may not see a high prevalence of those with those populations. But once we get individuals who are chronic, that begins to change a little bit. We start to see more fear avoidant behavior, more depression, and so these are factors that likely led them to that point of having chronic low back pain, and now we're going to have to deal with those. So when we think about a pain response, we can look at really one of two ways that a patient can go. Number one, they can be confrontational with respect to their pain, or they could potentially be avoidant. Of course, there's a middle ground there at some point as well, but our main concern here is the avoidance behavior that we sometimes see, as that is considered to be maladaptive because it's associated with chronic levels of disability as well. And that avoidance behavior that we see results in physical disuse, deconditioning, and guarded movements. And so those are the populations that we're most concerned with, are those individuals who are exhibiting avoidant behavior. Once again, that's maladaptive. We need to evaluate for it, and if it's there, we need to make sure that we're treating them appropriately. This is just a graphic that shows you what we just talked about in the last slide. So we have that injury experience, and we can go one of two ways. We can go toward that confrontational side where we see individuals who go through rehabilitation. They're not necessarily concerned about re-injury or making themselves a whole lot worse, and so they usually have a pretty good outcome. However, if they follow that pathway on the left, we begin to see pain that causes catastrophizing type behavior. They develop fear. They develop avoidant behavior. We mentioned it. That is maladaptive, that pathway right there. And we begin to see disuse that leads to disability and depression. And again, we start to think about, well, why does this happen? And we talked about this a little bit previously, but we start to think about what is somebody's thought regarding a pain experience. And is there a need for them to catastrophize this? And I'll sometimes use this pain experience, and we've used this before, as the fire alarm in your house. And so that fire alarm can go off for a lot of different reasons. One, like I said, it could be something that, you're burning toast and the fire alarm is going to go off first thing in the morning. or it could be the house is burning down. And so those are opposite extremes there. And so when that fire alarm goes off, sometimes we got to let folks know that, the house is not burning down. We're just burning toast here, right? And what that really means is that these anatomical structures in our body, they're not injured. And that's really not what's causing the pain response. They're not injured severely, they're strong, and they're going to recover. And so that painful response, there's many different reasons we have that, but it's not because that we have structural abnormalities with respect to the spine. And so we'll talk more about that, but that's a key to helping our patients try and understand what that painful response really means. This graphic, I think, shows the importance of building a therapeutic alliance with your patient and how that could potentially play into these fear avoidant behaviors. And so the diagram on the left here deals with this patient-therapist interaction that eventually leads to negative coping strategies, fear, and catastrophizing. Whereas on the right, we're dealing with a therapeutic alliance being developed between the patient and the therapist. We're looking at developing trust with the patient. We're improving self-efficacy. We're developing positive coping skills. And we're going to use calming statements. And we're going to ask patients to reinterpret their pain. We're going to ask them, to think about why they have their current symptoms, what are some of the aggravating factors, etc. And we're going to try and mitigate all that really to improve their function. But in the end of the day, that diagram on the right really relates to building this therapeutic alliance with the patient. It's based upon trust, improving their self-efficacy, and developing positive coping skills. There are several attitudes and beliefs and behaviors associated with fear avoidance beliefs, and I think it's important just to have a feel for this because, again, we're looking at gathering data and understanding the big picture here, and we can use a fear avoidance belief questionnaire to help us with that, but we're likely going to see attitudes and beliefs and behaviors. And so if you look at some of the attitudes and beliefs, it's the belief that pain is harmful and disabling, and they're going to be fearful because of that. The thought that all pain must be abolished before returning to activity, the expectation of increased pain with activity or work, and a lack of ability to predict those capabilities. These are folks who catastrophize, always expecting the worst. They believe their pain is uncontrollable, and they have a passive attitude toward rehabilitation. All of those you could see could really lead to a very negative interaction with respect to physical therapy. Some of the behaviors that we see, prolonged use of bed rest, which we know is not something we want to see. They reduce activity, which again leads to disuse and more disability. They avoid normal activity, and they have extremely high pain intensity, meaning their reports on a numeric pain rating scale are going to be 8, 9, and 10. You're going to see them using things like braces and crutches and other assistive devices. Their sleep quality will be reduced. You may see them self-medicating with alcohol or other potential substances. And these are individuals as well that we see have a higher prevalence of smoking associated with this as well. And so, again, these attitudes and beliefs and behaviors, you can see these here. These make it challenging from a rehabilitation perspective again. So I think that therapeutic alliance, developing self-efficacy, and these positive coping skills to help patients kind of reinterpret their condition, that's going to help developing long-term positive outcomes with these individuals. And so we've talked several times about the use of relative rest with respect to musculoskeletal injuries and the role that relative rest plays in the recovery process, and it does. And it really works best for individuals who are in those acute and maybe even subacute phases. But these individuals who are in chronic pain, when we tell them to avoid behavior, it really doesn't necessarily do them any good at that particular point. It just probably makes things much worse. And so with respect to chronic pain and whether or not we should tell individuals to avoid behaviors that make them worse, we would think that this is something that we want to have some concern over. However, we look at physical therapists and physicians, and the majority here agree that their patients should avoid movements that are painful. And these are individuals who have chronic symptoms. And so it's commonplace that many providers are going to recommend avoiding behavior that makes their symptoms worse. And it may seem a bit counterintuitive at this particular phase to say that, well, when we're dealing with individuals who have pain, and now we want them to confront their symptoms. And so again, we're going to make sure that we screen these individuals for sinister pathology. These are not individuals who have things like underlying fractures, these large disc herniations that we spoke about. Those are individuals we're going to keep a close eye on. They have good reason, right? They have true pathology, and that's the reason that they have their symptoms. But these are individuals who we look at their scans, there's minimal pathology there. We're not going to make them worse by telling them to continue to confront and do more activity. We want them to do more activity so that they see that the more activity they do, actually, the better they become, and they're not going to get worse. So again, it's commonplace for providers to say, let's avoid activity that makes you worse. But in these particular cases here, in patients with fear avoidant behavior, that just makes the clinical picture more complicated. So we've already mentioned a couple of key points when we're dealing with managing individuals who have fear avoidant behavior. We're going to begin by developing a therapeutic alliance with our patients. We're going to develop a relationship based upon trust. We're going to try and improve their self-efficacy, and we're going to encourage positive coping and really a reinterpretation of their pain experience. We've also mentioned that we're going to avoid having them avoid the activities that make them worse. In fact, we may actually push them toward some of those activities, and we'll talk about that in a minute. So again, we want to make sure these patients are going to be active. We want to use caution with having them restrict or limit their activities. And so what are some other strategies to manage fear avoidance behaviors? Well, first, we need to make sure we assess for it early in the course of rehab. Again, I think there's some usefulness in evaluating acute and subacute patients for this, but we're likely going to see this mostly with patients with chronic, with more chronic disorders. And so from a time perspective, we're talking about probably 6 months of low back pain. Those are patients that you want to evaluate for sure with a good, reliable, valid measure. And we want to make sure that we offer appropriate education for our patients, and we'll talk more about that. But one component of that is making sure that we're using caution how we describe anatomical findings. And so we want to be careful, especially when we have anatomical findings that we're not sure of the significance. And so I mentioned on a previous slide, if we're dealing with fractures or these large disc extrusions that we don't see in normals, right, there may be reason for a patient to potentially avoid behavior that could potentially make them worse, because we're still in these stages where we're trying to figure out their condition. And again, those are patients who are likely going to be potentially more acute or subacute. We want to de-emphasize anatomic findings in individuals. We want to be sure that we're very positive with our approach to interpreting imaging scans. We want to encourage folks to take a positive role in their recovery. We want to encourage self-efficacy and positive coping skills. And when we think about treatment, it's really going to be this graded exercise approach with the goal of trying to improve activity tolerance, and it really isn't to relieve their pain. So we need to make sure that they're semi-aware of that up front, that the primary goal here is to improve their level of activity and to improve their tolerance for activity. Specifically, we're going to reinforce this confrontational response. Again, this may be counterintuitive to this whole concept of relative rest that we've spoken about before and screening for aggravating factors. But these are individuals, again, who are more chronic, and their avoidance is actually making things worse for them. And so in this particular case, activity is going to be positive for them because we are going to prescribe the quota based upon what we believe is important. And so we're going to evaluate the patient. We're going to prescribe an exercise program based upon intensity, duration, and reps that we think the patient can tolerate, and it really isn't in regard to their response to pain. And so once we start to have patients perform this particular exercise program and they're not getting worse, all of a sudden that changes that cognitive component, that thinking component, and now all of a sudden they're doing behaviors and they're not getting worse. So now their thinking is going to change a little bit. We're going to continue to give positive reinforcement when exercise quotas are met, and the quota is going to continue to be progressed until that functional level is achieved. The gold standard for evaluating avoidant behavior would be the Fear Avoidance Belief Questionnaire. We've presented this to you before, but it's worth reviewing quickly. The top part is going to be related to physical activities. The bottom part is going to be related to work-related activities, and on the next slide we'll review the scores again that you want to look for to determine if we're dealing with individuals who have avoidant behavior. Because fear avoidance beliefs, again, are going to be a significant factor in predicting long-term disability and potential concerns with return to work, we want to assess for these early on. And the cut scores that we want to look at for that top physical activity scale, anything more than 15, and for the work subscale, anything more than 34. If we see changes beyond those points, those are individuals that we're likely going to have to make modifications to their rehabilitation program. On the back side of our patient intake questionnaire, question 4 there is one question that's come off the fear avoidance belief questionnaire, and it looks at should patients do physical activity that make their pain worse. We're asking the patient that. And if they say they agree with that statement or they're unsure that they should not do activity that makes their pain worse, that one question is essentially as valid as the entire questionnaire. And so if a patient tells you that they should not do activities that make their pain worse, if they're unsure about that or they agree with it, you can pretty much just assume that they have avoidant behavior at that particular point. And so if you didn't want to use the entire fear avoidance belief questionnaire, that one question right there is also going to help clue you in to the person if they're at risk for avoidant behavior. That second question on there as well, do you expect to return, or that next question, the fifth question on the intake, do you expect to return to the activity levels you were at prior to developing these symptoms? You know, if we get someone who tells us no with that, if they don't expect to return, again, we're thinking about psychosocial overlay and potential avoidant behavior. And so if they answered no to expecting to return to high levels of their pre-injury levels of activity, and if they tell us that they should not do physical activities that make their pain worse, those are patients that are going to have avoidant behavior. One other tool that can be used to evaluate for psychosocial overlay and potential avoidant behavior is the Start Back tool. We've introduced this to you previously, but again, it's worth mentioning again that you could use this. It has been developed for physicians, again, to determine what type of treatment is necessary for their patients. And again, this instrument has 9 questions. The first 4 deal with physical function, questions 5 through 9, those deal with this psychosocial concerns. And we're going to look at the score, and then we'll go ahead and make an interpretation on that. To evaluate the Start Back screening tool, we're going to look at the total score on the instrument. If they score 3 or less, they're low risk. Those are individuals, again, that maybe need 1 or 2 visits just to get them the appropriate education, help them with maybe an exercise program, talk to them about prognosis, which is going to be very, very favorable. And if they're not better in the course of the next 2 to 4 weeks, they should come back to see us. If they score 4 or more, we're going to look at the psych score. If they score less than 3 on that psych score, they're medium risk. What does that mean? Well, these are folks who likely need a course of rehabilitation, a course of physical therapy. Do we need to change up our management strategies to address avoidant behavior? No. We can use our treatment-based classification scheme, use traditional models of rehabilitation. Those folks are going to be fine. But if they score 4 or more on the psych score, those folks are at high risk for developing chronic disability. Those are folks that we have to change our management strategies to address avoidant behavior. And when the Start Back tool was developed, again, it was developed for primary care physicians to help them triage their patients to determine where should they go and what type of care do they need. And so those low-risk patients, that's going to be the bulk of these individuals we're going to evaluate in the primary care setting, low risk of chronicity. Good sound advice and education, reassurance, maybe some medication, non-steroidal, and we can treat these folks with manipulation, give them an exercise program. 1 or 2 visits is enough, and let these folks go. Very positive prognosis. If they're not better in 2 to 4 weeks, we give them our business cards. They give us a call back, or if you get worse. These folks who are medium risk, these are folks that are going to look at the instrument. They're going to score more than 4. We're going to look at that psych score, and they're not going to have this psychological component associated with it. These are folks who potentially need a course of rehab to get better. Right? If they don't get rehab, we know that they're likely to progress on to chronic disability. So these are folks who need probably 6 or 8 visits with a PT. Use a treatment-based classification scheme, get these folks in the appropriate category, and you get them better and they do fine. Those high-risk folks, we don't see a lot of these folks, right? But these are the individuals who have psychological obstacles to recovery. This is what we call the enhanced package of care. It's a more complex management strategy where we now employ these principles to deal with folks who have psychosocial overlay. But the bottom line here is the Start Back tool is an important tool you can use to evaluate for these types of behaviors. I don't think you need to use both, the Start Back tool and the Fear Avoidance Belief Questionnaire. I'd say pick one. My preference is to use the intake, and you can look at that one question on avoidant behavior on there. I like to see the Start Back, like to see where they're at, because it helps me kind of understand from a triage perspective as to what I think the patient's going to need. In addition to screening, we talked about appropriate education and de-emphasizing anatomic findings. Let's go ahead and review the education that's going to be necessary for these individuals. So these are the educational recommendations from the Physical Therapy Clinical Practice Guidelines put out by the orthopedic section of the American Physical Therapy Association. And they start by telling therapists what they should not do. Number 1, we do not want to recommend bed rest. So these are patients who are already going to be prone to bed rest and avoidant behavior. We don't want to do that. We want to be very cautious about our pathoanatomical explanations for a specific cause of low back pain. I recommend using caution with that. If patients ask me about a scan, I will definitely talk to them about it, but I'm going to focus on the positive aspects of it, and I'm not going to focus on one disc that potentially has a small herniation or maybe some central canal stenosis. Again, these are likely going to be findings that we know we see in a large number of asymptomatic individuals, and so there really isn't a need to focus on that. I think focusing on the positive side of this is really what's going to be helpful. Again, we want to emphasize this anatomical structural strength of the spine. They need to know that the spine is a strong structure, right? And just because you have pain doesn't really mean that there's damage there. We've already talked about the pain perception. There's many different ways of approaching that. I like to use that fire alarm analogy, but there's other ways of dealing with that. And sometimes you have to restate that over and over to a patient because the first time they hear that, right, they're a little taken aback, right? My pain's not real. What are you trying to tell me here? All we're saying is that when that fire alarm goes off, there could be many different reasons why. And we're just asking individuals to reinterpret that. As they progress through therapy and they see that they can do activity and they're not making themselves worse and they're actually getting a little bit better, again, that's going to change that thinking. It's going to play into that. We want to discuss the favorable prognosis for low back pain. We want to discuss a stay active approach. And again, our goal is to improve activity. We're not going to be so concerned about pain relief. We need to make sure that individuals know that up front. Our goal is to make them function better. And a side effect of that is that their pain is going to likely decrease the more they move. But our main goal is not necessarily to take a passive approach to rehabilitation, consistently addressing pain at each visit. Our goal is to address activity and continuing to push that in a safe and effective manner. I've mentioned before that one of the key management principles for these patients who have psychosocial overlay is going to be this back book. And so I just looked on Amazon. Looks like it's kind of tough to get right now, but you can usually buy packs of 20 of them for about $20. And so I would recommend that when you guys get out to your practice, that this is a book that you want to continue to use and employ, because the principles in it are really, really quite important. And so, do you have to give the back book to every patient with low back pain? I don't think so, but for these individuals who have fear avoidant behavior, it's important you give them a little bit of a reading assignment out of this. And it's not very big, maybe about 20 pages or so. But I mean, it's a small pamphlet, but let them read it, and then we talk about it and make sure we reinforce those findings. But what does the back book really do for individuals? Number one, it talks about abnormal imaging findings, because these patients have had scans and stuff's going to show up on them, right? And so wherever we thought that, you're 50 years old and you're supposed to have a normal scan of your lumbar spine, I don't know where that came from. We think about normal anatomy all the time, but as we age, things are going to change, right? Our hair changes color. Some of us lose our hair, right? Some of our bodies don't look as good as it used to. So we're changing on the outside. We're going to see changes on the inside as well. And that's part of the normal aging process. Sometimes we have to talk to patients about. And those findings that we see on imaging, that's rarely a sign of serious disease. And you got to be careful with this, but we need to let folks know that it's kind of hard to determine the significance of it, because many times these are seen in normal people. And so we have to be cautious with how we approach that, but the key really here is that it's rarely a sign of serious disease. When we have back pain, again, the spine is strong. It can take an awful lot of stress. And just because we have pain doesn't mean there's permanent damage, right? And it means that we can still have a positive prognosis. We can still get better despite the fact that we have low back pain. But again, the spine's strong, and it's not a sign of permanent damage that we have low back pain. And then the treatment of low back pain. There's a number of treatments that we can use, but the lasting relief, the lasting long-term relief, the lasting long-term benefit is really going to be dependent upon the patient. And so our main goal is to concentrate on maintaining and improving their activity. Our goal is to restore normal function and fitness. That's our main goal, improving activity, right? We're not going to focus on pain so much with these folks that that's all they think we're dealing with. Our goal is to get these folks moving, because remember, from a cognitive behavioral approach, right, their thought is that movement is bad. Movement's going to make them worse. So if we can get them moving, that's the behavior, and they're not making themselves worse, maybe they're getting a little bit better. Now all of a sudden their thinking is going to change. And then finally, we're going to develop that therapeutic alliance. It's based upon trust and negotiation. We're going to utilize positive attitudes and positive coping strategies. We want to make sure that patients are aware of that everything that they do is based upon their effort. But once again, we're going to help them function. We're going to use positive strategies to really begin to reinforce these behaviors that we want to see. And it's important to know that by the time patients have got to you, they've likely received lots of information. And it's likely that much of the information they received has been based upon the biomedical model, which we know just isn't really the best way to manage low back pain. And so the traditional biomedical model really talks about these basic principles of anatomy, injury, and damage. And that if we do see anatomical change at the spine, it may be consistent with damage to the spine. We recommend avoidance of activity when someone's in pain. Right? We talk about interventions, but we don't necessarily stress the importance of their involvement with them. And we even talk about non-conservative care like injections and surgery. And we really focus on the pain and not necessarily the activity. And that approach really encourages the patient to be a passive participant in this process. Again, the relationship we want to build with patients is one based upon trust and negotiation. Right? I give patients options all the time, right? After I evaluate patients, especially these folks who are chronic, I've already showed you the guidelines from the American College of Physicians. And so there are several different ways we can approach someone's chronic low back pain if there's psychosocial overlay. And so we can work together in therapy, maybe 1 or 2 days a week, right, up front, and then maybe one day, maybe once a week, or maybe once every 2 weeks. But there's other things that I want them involved in, and I want to know what they're interested in, right? Do they want to participate in yoga? Are they interested in potentially doing Tai Chi? Are they interested in seeing a provider who may help them with some mindfulness or some stress relaxation? Right? Are they interested in doing something like pool therapy? Right? And so all of these activities that I want them to be able to do, it's a negotiation. Because I'm not going to be the only one who's going to get these folks better. It's going to take time and effort on their part, and I'm looking for long-term solutions to their problem, and they need to move. And so I'll start them in therapy, we'll get them moving, we'll get them doing some activities, but there's those other components there that are very positive for individuals. We want to make sure that we continue to encourage that with our patients. The passive approach that I'm going to heal them or I'm going to fix their problem really isn't necessarily paramount, and it's really quite counterproductive in these cases. And so we've talked about these adaptive or positive coping strategies previously, and I think it's important to bring them up again here. And so when we start thinking about adaptive coping strategies, what do these typically entail? Well, first off, it really deals with confronting the problems that we're dealing with directly. And so many times I'll sit down with a patient and just develop a plan for the course of the next week. Right? What are things that we're going to do that are going to help you directly deal with your current concern about your low back pain? And we'll list 2 or 3 things we can do each day. Each day we have to have a plan. And then that plan is going to be important to carry that out. We want to make sure that we're reasonably appraising the current situation that we're in. And we want to make sure that we're avoiding unhealthy emotional reactions. So I already mentioned that these patients are typically going to have negative coping strategies. Their main coping strategies will deal with fear and catastrophizing with respect to events. We want to encourage positive coping, right? We want to encourage self-efficacy. We want to use calming statements, and we want to focus that with the patient. And we also want to help the patient to reinterpret their pain experience. Again, this sounds challenging, and it is. I've also mentioned that some of these patients who have chronic low back pain, it could take anywhere between 3 and 6 months for them to get better. And so these are patients who are going to want the quick fix. They're going to want to, be involved in a passive approach to their rehabilitation, and that's not what this is about. And so these patients are challenging. We're going to be dealing with them for a while, and they are challenging. And this is really why low back pain is the #1 cause of disability, and why so much money is devoted to it, and the outcomes aren't positive, because these really take work and effort on the part of the patient and the therapist. And the therapist has to convince the patient, right, to follow these strategies, which is very difficult, because ultimately what we're trying to do is avoid these adverse effects on the body. Because when we avoid and when we employ principles of disuse, we see deconditioning, we see atrophy, we see weakness. And those are things that are going to not only influence the musculoskeletal system, but also many of the other systems that we deal with. Think about diabetes and think about cardiovascular disease and things like that. We know that exercise and fitness helps folks who are depressed, who are anxious. That's why we see Tai Chi, yoga, mindfulness-based behavior, different types of stress reduction programs as being very positive for folks who have chronic low back pain, because it really plays into that idea. And so again, these adaptive coping strategies will be important. We want to make sure we employ them with these basic principles that we'll continue to outline through the course of rehabilitation with these patients. We've mentioned that we're going to have individuals take an active role in their recovery. And one way to do that is through this graded exercise component here. Again, our goal here is to improve activity tolerance. We're not necessarily so concerned about relieving the patient's symptoms. Again, we're going to look for a confrontation response based upon a prescription of an exercise program that we're going to develop. Positive reinforcement is going to be given, and then we're going to continue to progress that program based upon our experience and our knowledge, right, of the patient's impairments, right, until the patient meets their functional level that they'd like to achieve. And so let's show you an example of an exercise program that we might use for a patient who has elevated fear avoidance. And so before we show you the exercise prescription, let's talk about some of the basic guidelines and decision-making process that we're going to use to kind of come to those decisions. And so first off, we're the ones who are going to determine what the exercise quota is going to be. Prior to exercise, we're going to want to make sure that we get a good score on pain intensity. The patient's then going to exercise, and then we're going to assess pain after the exercise program is completed. I mentioned before that the main goal here is to improve activity, not necessarily to relieve pain. It doesn't mean we're not going to assess pain, because part of this process is that we want the individual to be able to exercise and move and do activity, but hopefully not make themselves a whole lot worse. And so we're going to prescribe the exercise based on what we think the individual can accomplish, but hopefully we're not going to see large increases in pain. If we do, we may have to back things off a little bit. We're not necessarily going to get the patient involved in that, but we may have to back things down. And so normally for me, if I prescribe this graded exercise prescription, I normally am okay with pain increases up to maybe 1 or 2 on that numeric pain rating scale. So if a patient says their pre-intensity pain was maybe a 2 or a 3, I'm okay if it jumps to a 4 or a 5. But if it gets higher than that, we may be doing too much. We may have to back that down. Okay, and then, is the exercise quota met? If it's met, right, especially if the pain has been controlled during it, we're going to give positive reinforcement, right? We're going to continue to reinforce that program, and we're likely going to increase the exercise demand on the patient. If, however, they don't meet the quota, right, our goal then is to determine why that is. We want to be cautious with providing positive reinforcement if the patient is not achieving their goals. And so we're going to step back a little bit, review those adaptive coping strategies, review the reasons why we're doing what we're doing, and we have to ensure that the patient is beginning to meet those goals. And so we're going to use these basic principles of reinforcement to assist in exercise completion, and then we're going to continue to determine if we can increase the intensity of the exercise based upon how the patient's performing. So this is an exercise program that was part of a published case report that's in your reading for this particular week. And I'd like you to skim the paper, and just so you can have an understanding of some of the principles associated with management of these patients who have fear avoidant behavior. And so if you look at these exercise sessions, these were prescribed for an individual who had fear avoidant behavior. And you can see that they assess pain prior to exercise. Then they have the patient go through. It's a very standard program. With some prone press-ups, quadruped hip extensions, some bridging, some hamstring muscle stretching, and then walking on a treadmill for a period of time. And then they reassess pain intensity after exercise. And you notice that the exercise intensity or the pain really didn't change that much. Now you look at that program and you say, well, I mean, there's not a whole lot there. But there is, right? This patient had a little bit of a directional preference as well toward extension, and so those prone press-ups played into that. We're not going to give the patient a very detailed anatomic description as to why we think the pain is there or what that prone press-up is doing, right, with respect to the disc and using models of jelly donuts and tubes of toothpaste and things like that, showing them models of the spine with the disc herniations. We don't want to do that. Prescribe the exercise program. There's a bit of an extension bias here, and that's likely going to assist the patient. Again, you can look at the 6 exercise sessions. You can see pain decreasing over time. And the key here is that we're assessing pain prior to and following exercise, and we continue to increase the intensity of the program. If by chance the pain may have increased significantly from a particular session, we may have to back that down a little bit. Take it in the opposite direction, back it down a little bit, but then build that program right back up. And so this is a nice example of a program that you would use for a patient who potentially has fear avoidant behavior. So graded activity is one approach that we can use to potentially rehabilitate patients who have avoidant behavior. The other approach is graded exposure, and this is called the Fear of Daily Activities Questionnaire. And so in this particular questionnaire, we're going to look at activities that a patient's most fearful of. And you'd say, okay, these concepts of avoidant behavior, we're having patients confront their activities. What is this going to do for me? Well, we want to find the activities the patient's most fearful of and gradually expose them to that. So if a patient tells us that lifting and carrying and bending is what makes him worse, these flexion type activities, believe it or not, those are activities that we're going to want to include in our rehabilitation. And so why? Again, these are not patients that have pathology. These are not patients that have large disc herniations that us doing flexion activities are going to make them worse. These are patients who may have some abnormalities on their imaging, but they're minimal. And so we know that the spine can take these forces, and it's due to a concern over activity. That's the reason the patient's avoiding it, because of concern for pain. And so we find those activities that are most painful, or most fearful rather, and we move the patient toward those activities in a safe and efficient manner. That's a concept of graded exposure. You'll hear about that in the literature. Both graded exposure and graded activity, both have been shown to be helpful in individuals with fear avoidant behavior, but this is one other option that you can use to potentially manage these patients. So let's take a moment and review what we've discussed so far and talk about some other considerations for individuals with fear avoidant behavior. We've already spoken that our program is going to focus around offering appropriate levels of education for our patients and encouraging the patients to take an active role in their recovery. We're going to use concepts of graded exercise to really develop a program and move that forward. We could have a patient complete the Fear of Daily Activity Questionnaire, and that would tell us what activities they're most fearful of. Again, it's a bit counterintuitive, but those activities they're most fearful of could even be some of their aggravating factors. But because we know that their anatomy is sound, we know that we're not dealing with sinister pathology like fractures, we can move these patients forward with some of those activities through these concepts of graded exposure. And you've probably seen graded exposure with other phobias. You've probably heard of these. For example, if patients sometimes or individuals have fear of spiders, how do we deal with that? Well, we expose them gradually to the concept of spiders. So we may start by having someone look at maybe a children's book, right, that has spiders in it, cartoon characters and things like that that are non-threatening. Then maybe we have a stuffed animal of a spider, right, in the individual's room. And then maybe we have a model of a spider, that's a little less threatening, but a plastic model of a spider. And then maybe we have a spider actually in a cage once the individual is able to tolerate that. And so we can gradually expose them to these various levels of threat, and then hopefully the individual is going to become less fearful of that particular activity. It's the same thing with movement. And we can look at a graded exercise program. We can use concepts of graded exposure with that. We can also incorporate directional preference in that as well. As I mentioned, if a patient has a directional preference, we can certainly move them in that direction with our exercise program. If they have an extension bias, using activities like a prone press-up, quadruped arm and leg, bridging activities, or we know extension forces are being introduced to the spine, that's very helpful. That individual may also have some concerns with some other activities that they're fearful of, and we're going to make sure we incorporate those in at some point as well when it's reasonable and safe. We're always going to assess pain prior to and following each activity, and if we're not noting increased pain, and if we know the patient can successfully complete the exercise quota, we're going to reward the patient with positive feedback, and we're going to progress that program. You may ask, what about manual therapy? What about modalities, right? What about other passive interventions? The treatment-based classification scheme, again, was really devised for individuals who were in those early stages following injury, right? Patients who were acute or subacute. It really didn't necessarily incorporate the concerns about fear avoidant behavior when we developed, when that program or that treatment-based classification scheme was developed. So when you try and classify patients who are chronic into that model, we really don't have the evidence to support that. As I mentioned before, if you go back to the guidelines by the American College of Physicians, they're quite clear. The treatments for patients with chronic low back pain are very different than the treatments for acute and subacute patients. And so, can you use manual therapy? You can. I would be cautious with it, though. I would be cautious with the use of modalities. I'd be cautious about the use of other passive interventions, because that feeds into the patient's fear avoidant behavior at that particular point. So if you use manual therapy, I would say use it for a visit or two. Certainly don't make it for the focus of the intervention, but let's say maybe you want to improve hip extension a little bit. You want to mobilize the hip or mobilize the lumbar spine. Go ahead and do it. But again, we're going to tell the patient that's essentially going to help them do their program better. And so by cleaning up some of those impairments, that may definitely help with helping them complete their exercises more efficiently. So you can use these modalities, you can use manual therapy, but I'd say use them very sparingly and only when necessary. We need to be cautious, because that could definitely feed into some of these concerns over the patient and their passive approach to rehabilitation. So in this particular presentation, we covered several different aspects. We talked about Waddell's nonorganic signs. We talked about how to screen for depression. And then we talked a little more about fear avoidance, how to screen for it, how to appropriately manage it. I want to thank you for your time, and I hope this was a value-added presentation for you.